aortic developmental disorders. It is a complex disease process which causes stenotic lesions in the descending thoracic and abdominal aorta, causing narrowing and stenotic lesions in the branches to the kidneys and to the splanchnic vessels. And appropriately planned and conducted vascular reconstructive procedures provide a durable benefit in majority of these patients. In these images, you can clearly see there is narrowing in the pararenal and infrarenal aorta with narrowing of the renal vessels as well. And in this image, you can see there is a near complete occlusive lesion of the suprarenal aorta with additional accessory renal vessels arising from the infrarenal aorta. The abdominal coarctation or segmental aortic hyperplasia was also being called earlier as a middle aortic syndrome. The contemporary classification is based on the cephalad extent of the involved aorta. Majority of the cases being suprarenal, close to 70% of them, next being the intrarenal, and lastly being the infrarenal cases, which are less than 10% of the cases. The diffuse hypoplasia of the abdominal aorta is included in the spectrum of the disease as well. The embryological etiology and pathogenesis is because of overfusion of the two dorsal aortas during the 4th week of gestation. The two dorsal aortas extend along the entire length of the embryo, containing dorsal, intersegmental, lateral segmental, and ventral segmental branches. The two dorsal aortas fuse at these, and some branches persist, involute, dilate, or join together to form the name branches found at birth. But and the loss of paired lumbar arteries with the hypoplastic aortic segment with only one single lumbar artery exiting the trunk and seen in dorsal aorta in cases. Multiple renal arteries to one or both kidney occur in these patients with nearly to twice the frequency in general population, because as the aorta shrinks when close to the birth, the normal accessory renal arteries which supply the kidney during the gestation, which usually involute, do not involute in these cases, and as a result persist as multiple renal arteries. Associated genetic syndromes and inflammatory diseases which are associated with it are most commonly neurofibromatosis 1, which is the most common of it. Others being Williams syndrome, Alagille syndrome, and tuberous sclerosis. All these interfere with the cell growth in the vascular tissue and the cellular death during development. NF1 is the the phenotype, which is a highly variable disease with a wide spectrum of vascular involvement. It causes vascular manifestations, other vascular manifestations such as aneurysm, EVMs, cardiac valvular anomalies, direct neural tumor invasion, or compression of vascular structures. Hypertension is the most common presentation of neurofibromatosis type 1 as a result of renal artery stenosis or aortic narrowing. And more than 25 patients of abdominal, 25% of patients of abdominal aortic aortation or segmental hypoplasia will be diagnosed with NF1. Maternal rubella during the first trimester is one of the inflammatory causes of coarctation. Takayuki aortoarthritis is also one of the lesser known causes because it usually affects the arch of the aorta and the proximal descending thoracic aorta, not the abdominal aorta. And other non-developmental abdominal coarctation is seen because of umbilical artery catheterization in neonatal period. However, this catheterization is more likely to lead to aortic thrombus formation rather than coarctation. Developmental renal and splendic arterial stenosis are also seen mostly in conjunction with the coarctation. The splenic stenosis is more common as compared to the renal arteries. However, the renal artery stenosis is more symptomatic as compared to the splenic cases. Etiology of the pediatric renal artery stenosis, usually in Caucasian children, it is a developmental etiology, whereas in the developing countries in Asia, Africa, and South America, it is inflammatory aortoarthritis or Takayasu related arthritis. Majority of the renal artery narrowings are located in the ostia and represent a true hypoplastic stenosis. The affected arteries are very small. The abnormalities are present in all layers of the vessels, causing internal proliferation, medial thinning, and excessive adventitial elastin. This is a histological view of the cocted vessel, showing proliferation of the intimal tissue, medial thinning, and excessive adventitial elastin. The ostial stenosis of the celiac artery and SMA also do occur, but minimal CA and SMA narrowing at the young age may not increasing the diameter as a child grows. Hence, when the child is young, there is no quite often there are no symptoms. But as the child grows, the artery's origin become proportionately narrower as the adjacent artery becomes bigger until the artery narrowing becomes critical and causes the symptoms to arise. As seen in this DSA image, where severe celiac artery and superior mesenteric artery stenosis is present. The clinical manifestations of these patients usually are in the form of hypertension, and it is the third most prevalent cause of hypertension in children after parenchymal renal disease and coarctation of thoracic aorta. The suprarenal or intrarenal aortic narrowings plus occlusions of the renal artery will lead to a compound to the problem of this hypertension. The resulting secondary hypertension in these cases is often refractory to simple pharmacological control. And majority of these patients usually present with three or more antihypertensive medications, and yet the hypertension is not controlled. The presentations will be asymptomatic high blood pressure, seizures, headaches, epistaxis, visual disturbances, acute renal failure, neurological dysfunctions due to isolated facial nerve palsy reported as Bell's palsy, and the chronic effects of the elevated blood pressures will result in arrest in kidney growth and atrophy with chronic renal failure. Unrecognized and untreated renovascular hypertension in children may lead to hemorrhagic stroke, hypertensive encephalopathy with impaired brain development, failure to thrive, and left ventricular hypertrophy with severe diastolic dysfunction, and finally heart failure. If the entire renal mass is involved, it might lead to something called as flash pulmonary edema, which is associated with renal insufficiency, which is uncommon complication. The high rate of celiac artery and SMA occlusive involvement is there, but the symptomatic cases are, however, only 6% of the cases. It is usually manifested as a postprandial angina, which periumbilical discomfort that lasts for the duration of the transit of the food in the small bowel, and the children usually develop food aversion and exhibit weight loss from failure to eat. As per the National Health and Nutrition Examination Survey, hypertension is defined as the normal blood pressure is defined as systolic blood pressure or the diastolic blood pressure, which is less than 90th percentile for the sex, age, and height of the patient. Whereas hypertension is when this percentile is more than the 95th percentile for the same criteria, and when these are measured on three separate occasions. Uh, the recommendations for these children is if the children are being evaluated in a medical setting and is more than 3 years old, BP should be measured by the auscultation method. And if the child is less than 3 years, BP should be measured if the patient has congenital heart disease, renal disease, urological manifestations, or other systemic illnesses associated with hypertension, such as neurofibromatosis or tuberous sclerosis. The renal Doppler sonography is the first imaging study to detect the renin-mediated hypertension caused by aortic or main renal artery disease. It has a 90% sensitivity and 68% specificity. Benefits being does not involve any ionizing radiation, low cost, and widespread availability. However, it is a operator-dependent modality, whereas and small vascular such as accessory renal artery and segmental branches are difficult to visualize. CT angiography is a good diagnostic modality with nowadays low dose CTA protocols being used to reduce radiation exposure in the developing age. The benefits being it produces a rapid imaging of the thoracoabdominal arterial structure with decreased motion related artifact and decreased need for sedation. It has excellent spatial and contrast resolution, and it permits high quality multiplanar 2D reformats and 3D reconstructions. Disadvantages being the use of contrast and radiation. MR angiography with the use of time-resolved three-dimensional cinephase contrast MRI may permit evaluation of the renal blood flow pre and post intervention. It has excellent contrast resolution, allows for 3D, 2D reformats and 3D recons. It does not involve any ionizing radiation and may obtain images with or without IV contrast material. Disadvantages being it is limited availability, high cost, lower spatial resolution relatives to CTA that limits the evaluation of small accessory arteries and intrarenal segmental branches, may exacerbate areas of arterial narrowing. Artifacts may result from implanted metal or patient motion, and younger patients might require GA. If a strong suspicion of renovascular lesion is suspected on a clinical history and examination, directly a digital subtraction angiography can be done, and it is a most valuable diagnostic study for patients in this population. Benefits are it has the best spatial and temporal resolution, excellent images of renal, arterial, lumen, and branches, and concurrent therapeutic intervention. The same server for GA in younger patients, it being an invasive procedure, and ionizing radiation is used. Cerebral vascular abnormalities are described in a very small percentage of the patient and middle aortic syndrome, that is only 3 to 13% of the patients. These include intracranial arterial occlusive disease and cerebral aneurysms. Screening children with the contrast enhanced axial imaging in the form of CT or MRI is usually advised. The first modality of treatment is medical management in the form of controlling the secondary hypertension. The goal of the therapy has to be to reduce the blood pressures to less than 95th percentile. And if LVH is present or other target or organ damage is present, it has to be less than 90th percentile. The drugs used are the ACE inhibitors, angiotensin receptor blockers, combined alpha and beta blockers, such as labetalol, beta blockers, atenolol, metoprolol, and such. Combined beta blockers and diuretics in the form bisoprolol and hydrochlorothiazide, central alpha agonists, calcium channel blockers, diuretics, peripheral alpha agonists, and vasodilators. It is recommended that a single agent be initiated until the target blood pressure is reached or until the maximum dose or a side effect of the drug is encountered, at which time additional agent has to be added. Antihypertensives that block the renin-angiotensin system, such as ACE inhibitors and angiotensin receptor blockers, are relatively contraindicated until the critical main renal artery stenosis or bilateral renal artery disease is excluded. And careful monitoring of serum potassium and creatinine is required in this ACE inhibitors and ARBs. The decline in renal function is mostly to occur when blood flow to the entire renal mass is compromised, such as in bilateral renal artery disease or unilateral disease in the presence of solitary kidney. Discontinuation of these drugs usually results in the return to the baseline function, and a rebound hypertension and tachycardia is usually seen in the sudden withdrawal of clonidine, particularly in troublesome children. And diuretic should be used as a combination therapy only, as isolated use may increase the renin release and exacerbate the hypertension. Coming to the surgical modalities, the main indication being the failure of medical therapy to halt the progression or diminish the left ventricular hypertrophy. The options available are a patch aortoplasty if it is an isolated abdominal aortic provide the anatomy. Thoracic bypass if the hypoplastic segment of the aorta is too narrow to facilitate a placement of the plus, or in cases of complex disease affecting the renal and splanchnic arteries, which requires a complex reconstruction of these bypass is suitable. Expanded tetrafluoroethylene grafts are favored over woven or knitted grafts for both aortoplasty as well as the bypass grafting because of the greater stability of PTFE regarding post-implantation dilatation. In patch aortoplasty, segment of the aorta has to have a sufficiently large diameter to allow completion of anastomosis without overlap of sutures on the opposite side of the patch. The aortic patches in children are size large enough to facilitate the match of the growth of the remaining aorta, but these patches should not be large enough so as to favor a low flow low velocity flow, and potential thrombus formation. The aortoplasty in these patients is often accompanied by complex renal and splenic aortic reconstructive procedures as seen in this diagram. The thoracoabdominal bypass graft should originate above the narrowed area, either from the distal thoracic aorta above the diaphragm using a thoracoabdominal approach, or from a supraceliac aorta at the diaphragmatic axis by an abdominal approach. Grafts are positioned behind the kidney with a gentle curve to the distal aorta. The sizing of the grafts follows the sizing principles used for patch aortoplasty. The intent is to oversize the graft compared to the aorta in recognition of the anticipated growth of the child at the aorta. Otherwise, the resultant graft may be too small to maintain the distal pressures and flow, requiring a reoperation. As seen, gentle curved and placed behind the left kidney. The basic diameter guidelines which has to be followed are in young children, a diameter of 8 to 12 millimeter grafts are used, 12 to 16 millimeter grafts in early adolescents, and 14 to 20 millimeter grafts in late adolescents and adults. Can avoid significant graft redundancy in older children and adolescents because the axial growth of the diaphragm to the pelvis is not significant after the age of 9 to 10 years. Aortic reoperations may be required for anastomotic narrowings or if the patient outgrows the primary reconstructive procedure, and long-term follow-up of these patients is generally recommended. The primary open surgical treatment of abdominal aortic coarctation for renovascular hypertension benefits in more than 90% of these patients, whether we treated with patch aortoplasty or a bypass, and the post-operative morbidity is low, and the most noteworthy complication being post-surgical pancreatitis. The follow-up of these patients can be done indirectly via non-invasive blood pressure measurements of the upper and lower extremity with and without exercise. ABI measurements, if they decline, a detailed imaging should be considered. And if imaging is done, MRA is favored as it avoids any additional radiation exposure. Late or secondary operations following surgical treatment of abdominal aortic coarctation or segmental hypoplasia approach 10% and were performed usually 5 to 12 years after the initial reconstruction. Coming to the renal artery repair, the renal artery stenosis may be found independently of the aortic narrowing or in conjunction with the coarctation, and is most often done to prevent a long-term sequelae of hypertension. The significant challenges exist in reconstructing very small and highly vasoactive arteries in an infant, and hence it is usually avoided till the age of 3. But in cases of uncontrolled severe hypertension or renal failure in the renal instance may require intervention in this young population as well. Renal artery implantation of the normal artery beyond the stenosis into the aorta or a non-disease adjacent artery is the most commonly performed. Internal iliac artery for aortorenal bypass grafts when need has proven to be a suitable conduit and is currently recommended if reimplantation of the vessel cannot be performed. Vein grafts which are utilized earlier is no longer a recommendation due to the high risk of aneurysmal degeneration, which is seen in more than half of these grafts during follow-up. Here is angiogram image showing internal iliac artery being used as a conduit for the renal artery reconstruction. In a recurring hypertensive state may occur when a splenorenal reconstruction is used, when the renal artery is implanted into a splenic artery, because in these cases, this narrowing in the splenic artery, which initially might have not have been hemodynamically significant, might become hemodynamically significant, causing a critical stenosis as the child grows, which causes a recurrent hypertensive state. The less common reconstructive procedures used are resection of the stenotic segment of the artery with a primary anastomosis, focal arterioplasty, and open operative dilatations, which are usually not done nowadays. Nephrectomy can also be an option in these patients in cases of non-reconstructible disease, multiple intrarenal stenosis not amenable to repair, diminutive non-functioning kidneys 2 to 3 centimeters in size, and nephrectomy is only only appropriate when the contralateral kidney is assumed to be sufficient in preventing from the child to going into renal failure. And if the scenario is such, a partial nephrectomy may offer a nephron-sparing cure for segmental renovascular hypertension, and this can be diagnosed by selective renal vein renin sampling. Blood pressure control outcomes after the open surgical management in these children were analyzed at three major institutes, which being University of Michigan, Vanderbilt University, and the Cleveland Clinic. And in all these studies, the respective cure rates were 70, close to 70%. The improvement rates was around 25%, and the failure rates were between 3 to 11%. Renal autotransplantation is also another option, which is safe and efficacious for complex and segmental renal artery disease without associated mortality. It has a negligible morbidity and a reasonable long-term follow-up. And the cure rate for hypertension may approach 62%, and the improvement rates is seen in 38% with preservation of renal function. The splanchnic arterial repair is done only in symptomatic cases, and the relative indication to prophylactically reconstruct the vessel exists when the performance of an aortoplasty or renal revacuation would make a subsequent celiac artery or SMA revascularization exceedingly difficult. Internal iliac artery grafts are usually used to treat lengthy celiac artery or SMA stenosis in young patients, and anastomosis are usually fashioned in interrupted sutures when reconstructing small arteries 2 to 3 millimeters in diameter. In older adolescents, our continuous suture may be used to complete this anastomosis. If a stenotic segment is short, aortic implantation of the celiac artery SMA after spatulation of the transected vessel beyond its stenotic origin is favored over a aortosplanchnic bypass. Patients treated by both methods are quickly able to gain weight and rapidly are freed from abdominal discomfort. Developmental stenosis in adults may be reconstructed with either vein grafts or synthetic conduits. Percutaneous balloon angioplasty with or without stenting in children of this ostial splanchnic lesions are usually not appropriate and ill-advised. It is important to remember that the celiac artery and SMA stenosis are asymptomatic as IMA takes over the effective collateral circulation. The long-term follow-up of these children with periodic imaging study in those operated upon seems appropriate. Uh, Unoperated patients should be made aware of the anatomy of the splanchnic arteries and be able to pass on this information to a future physician performing a later abdominal operation, because inadvertently interrupting this collateral circulation arising from the AMA might cause catastrophic intestinal ischemia in these individuals. The endovascular modalities in these situations are only select, where there is select focal abdominal coarctation distal from the renal and splanchnic branches, and they are not involved, and is most commonly used in treatment of stenotic diseases arising due to aortitis. The developmental aortic narrowings are prone to significant recoil from the hypoplastic and fibrotic segments, and stenting may be required to overcome this. But there is increased perioperative morbidity in comparison to open surgery, with complication rates approaching as high as 30%, with complications such as itorenal injury in the form of tears, aneurysm formations at the site of angioplasty, and stent embolizations may occur. There is an increased incidence of restenosis and reintervention with freedom from 55% at 1 year and 33% at 5 years in large series. The long-term benefits of these are still unproven, and the hypertension cure and improvement rates combined approximate only 60%, with failures ranging 32 to 44% and high rates of early restenosis. And this occurs because of early post-dilatation arterial recoil, and thrombotic complications are also very high in these patients, and it still remains a controversial therapy. Remedial operations following the failed endovascular treatments are more complex, are often not as successful as the primary operations. And the outcomes following these remedial operations included hypertension cure rates only of up to 25% and improvement rates of only in half the patients. Whereas in comparison to surgery, which has 70% and 27% rates. The patient selection for endovascular intervention, small vessel side and the fibrotic nature of this lesion, and stents are to be avoided in these cases as they increase the risk of neointermittent hyperplasia and recurrent stenosis, and do not take into account the later necessary growth of artery, both in diameter as well as the length. Here is a renal arteriogram demonstrating a incomplete stent expansion across the ostia with in a developmental renal artery stenosis with causing multi-drug resistant hypertension. Endovascular therapy should only be performed at a high volume center by an experienced team, and it is the collaboration of multiple specialties being nephrology, vascular surgery, diagnostic, and interventional radiology, cardiology, providing valuable insights into the complete management of this. Thank you, sir.